I know this thing is on, and I know that you can hear me. Nursing and healthcare needs advocates and activism. So what are you waiting for? Let's do the damn thing. Hi, and welcome to the Green Nurse Podcast, an unfiltered discussion related to health and healthcare. My name is Amie Archibald-Varley, and I'm the Gritty Nurse. So today we have such an amazing guest. I've known her for quite some time through social media, and she's done such amazing work. And I think it's always good that we highlight nurses because, nurses need to be highlighted much more on various different platforms. I think it's good that we have conversations about nurses who also have something that may be atypical that may happen to them. I think we do a really good job of looking after everybody else. But when it comes down to us, we're like, oh my gosh, particularly when it's our own health. So without further ado, I'd like to introduce to you Emily Edwards. She's a registered nurse and the founder of Nomad Care Consulting. She's an expert in dementia care and older adult mental health. Her experience includes working as a psycho-geriatric resource consultant, a long-term care behavioral supports coordinator, and an RN team leader for specialized dementia care. Emily started Nomad Care Consulting to assist individuals, families, and care teams in navigating the healthcare system, particularly in the context of dementia care. Welcome, Emily, to the Gritty Nurse Show.
Thank you so much for having me, Amie. I am very, very excited to be here.
I'm excited that you are here. I gave a quick overview, but I know there's always so much more because I think at the end of the day, like when nursing is like one part of our identity, but maybe you could tell us just a little bit about yourself, maybe why you became a nurse and kind of where you are on that nursing journey right now.
Absolutely. And yes, there's a lot more to it than that description. And really, dementia care is where I've landed. But that journey has been a long one. And I joke that I really believe that long-term care was where nursing careers went to die when I was your nursing student. And I laugh that that's where my passion is and I am now. But really by way of, I became a nurse because I thought I wanted to be a midwife and they did not accept direct like high school graduates. I took a year off and one of my best friends was taking an English degree and she jokingly was like, just go into nursing, like you're going to have a job when you're done. And it was like a light bulb moment though for me because no one had mentioned it to me. I was really incredibly intelligent, high grades, and it was just no one quite knew what to do with me, but no one ever talked about nursing. And ironically enough, the parent council president, I don't know if that was her title officially, but someone who really had my back in many ways as I in high school was the student council liaison. She was a parent to people I went to school with. She was also the dean of health sciences at Loyalist College, so our local college. So again, when we kind of converged, she realized I was thinking about nursing. She's like, yes, 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 let's get you here. Let's check it out. I really fell in love with it. Like I said, it was not on my radar. My grandma was actually an RN. Yeah, a social activist, an RN. She didn't do shift work well. She had a really cool story as well, but it wasn't something like no one else went into healthcare in our family. It just wasn't. So yeah, that was really where it started. I thought, again, midwifery. And I was like, I'm going to go into labor and delivery because that's what we all, again, think that is the pinnacle.
Right.
And I had a baby at the end of my third year of nursing. And I survived my third year of nursing pregnant. I fought tooth and nail to participate in that year and to continue on to my fourth year, despite a lot of like literally clawing my way through that. My partner, he was in the military. So we were fortunate that he had a parental leave that he took for 9 months. So I headed back to school with a breastfed baby who did not take a bottle. And he and his dad, struggled at home with a syringe and a spoon. He came to class with me sometimes. Like it was just an absolute nightmare. And actually, like as I'm saying this, one of my professors, I remember walking into class with him one day and I was always so uncomfortable doing that. But at the same time, I'm like, what do you do?
Right.
You got a baby who needs to be fed. You got somebody who can't, like, we got to figure this out. And I want to finish. The other thing was I was not willing to give up my fourth year or take time because I had a partner who had time to take off and we had a life to go live when I was going to graduate. He was posted in Saskatchewan at the time. And this professor looked at me and she's like, is that kid's dad West Indian? And I'm like, yes, his dad's from Grenada. He is. And she said, my girls are from St. Vincent. And I just remember being like, and
I'd be like, what? What's happening in this conversation?
Yeah. And I was like, okay. But it was that she was someone, again, in that journey that I was like, you recognize what I'm trying to do. And her story was really, really, really incredible as well.
Right.
So all of that to say, I got to the end of it and I was just like, okay, I'm finished. Like, I don't know what to do. And then I went out west and no one mentioned that I should register in Ontario before I registered elsewhere. So I waited months and months and like all of this. And then I just started working wherever I could work. I was on a trajectory where I think a lot of people thought I was headed for graduate studies, my PhD, and like just keep going with school and that kind of stuff. And then again, how life unfolded for us was it was a much different adventure. And I went, to northern Saskatchewan and I worked in a men's prison as a brand new grad. I worked in a rural hospital again as a brand new grad. I was
I was
the
gonna say,
RN in
yeah, that's
charge.
challenging.
Those things where, again, looking back, it's like I had no business doing that. None. But I would never have gotten the opportunity to really like expand myself as a nurse so early on because it was just sink or swim in that sense. And I had that's where I learned your RPNs, your LPNs are everything. You trust them and they're going to have your back and they're going to know when they need you. And so that brings us to, I've always done things unconventionally. And as long-term care came into my life, we resettled in the Belleville area. Again, the only place to work was long-term care because again, that's how it is. And I fell in love with it and I started to realize how complex it was. And honestly, I think that there's no more dynamic care space than long-term care in the sense of you are working with 90 or 100 years of someone's social and health history. You're working with families. You're working with very complex regulations that are not existent in other spaces. And it's also a place where nurses get to be leaders very, very early on in their career. And
Yeah.
it's something I love. And working with those folks, though, those families that have been impacted by neurocognitive conditions or those memory, like significant things that you just don't think are coming, like a dementia
Right.
or a young onset or a Parkinson's or something. It really drove home the fact for me that I was not waiting until retirement to do the things that I really wanted to do as a
Mm,
family, as a couple, as an individual. And so we've done really wild things, maybe. I don't know if that's the right word, but I
wild.
said I don't want to wait until then. And then we come to the fact that I think subconsciously somewhere my body knew that I wasn't going to get that time
Right.
to wait. My husband also is a retired Canadian Forces vet. I am a caregiver for a retired Canadian Forces vet with PTSD.
Wow.
A really different dynamic that I try to bring into like what I do in the sense of you never know what's going on at home or like what you see when someone shows up, you don't know what they'd had to do to get there or what they might have to do when they go home.
Yeah. What a powerful career trajectory. That's a lot, Emily, that you've done, and doing all of what you've done is quite amazing. And you should give yourself a pat on the back and say, "Hey, I've done a lot of things." And I think it's good to have kind of that diverse and eclectic experience because I think all of the things that we do in our personal life, outside of nursing, all the experiences that we have, and then this is kind of tied into atypical, where it's kind of like, all of these things shape who we are as an individual, right? We aren't just a nurse, we aren't just whatever. We are shaped by all the different experiences and things that we've impacted, we've been a part of, we've seen. And I think that, it sounds like you've had kind of an amazing journey. I don't want you to feel that the journey stopped. I found you as a travel nurse. So I remember kind of going through your page. It's like, look, she's done everything. I want to know more. But there's, like I said, just so much more. I didn't know that you worked in prisons, and I didn't know that you're a caregiver. I think I had an idea, but I didn't know that you are in a caregiving role yourself. And then just even your journey in nursing school, being pregnant. I remember I was pregnant in my master's degree, and one of the things I noticed is nursing is not the greatest for giving accommodations, which is like
Mm.
crazy because it's like,
Mm-hmm.
hey, we're in a
Yeah.
healthcare caring profession, but turn that lens inward and really help. So I'm glad that you did have some resources. But again, I'm speaking to the schools out there. We could do a better job at being a little bit more
Yeah.
accommodating to our nursing students. But
Yes, yes, yes.
like it should never be a struggle. Like it should be, this is how we're going to make things better, because you want that nurse to come out and do the best that they can at the end of the day. But we need to make sure that we're shaping it for all of the various journeys that we may be on. I didn't even
Exactly.
touch on nurses who are neurodivergent coming into nursing, because that's like a whole other conversation.
And
But
again,
I
if you've
want
worked
to
a night shift, you might know a few of them. Is my outlook on it.
We are the night shift nurses. I did not want to do a day shift for a variety of different reasons, other than the fact that, like it was quieter on nights. I felt that I had much more independence and just the noise and the bustle of, having to put on appearances for managers, directors, or, some political leaders coming in. And it's just like, I just didn't have the fortitude. And also because I'm somewhat unfiltered, I just couldn't.
Yep.
So,
Go
hey,
fight. It's where we
night
live. You
shifts are
find
where
your
it's at.
people.
Yeah, 100%. And look, I could dispute with other nurses, but I'm going to say that night shift is where it's at. You can fight me. It's fine. So one of the things that we kind of talked about at the top of the episode is nurses typically don't discuss their own health. I think, even just from a social media standpoint, we see the best sides of everybody. And, here's these most glamorous aspects of who we are as individuals. And we do not open it up. And I would say nurses too. We're not really good at opening up about what might be happening with us, whether it's mental health or, complex health diagnosis. And again, like we're really good advocates for others, not the greatest advocates for ourselves, but I think something has happened with you. And I've noticed that you have done a lot of advocacy in terms of your own health. I think it's important for nurses to see that we can be vulnerable, we can share our own health journey, because again, I truly believe that experience and that story can help somebody else, can help someone educate. So maybe it's something that they notice in themselves and they're like, oh, maybe this is something I need to look at. So I'm actually super proud of you, Emily, for being able to share what has been happening with you. And I think that you should be proud of yourself too, because you're helping other nurses without even knowing, and other people
Thank
just
you.
in general. So are you willing to share what's happening with you on your health journey?
I'm an open book when it comes to that, really, in the sense of exactly what you just said. If I can make sense of it, as you said in my bio, I am a psychogeriatric resource consultant. I'm a resource consultant and educator at heart. I like to make sense of things that are kind of nonsensical to most people, or to make them like more logical. And it just seems natural for me to do that for myself in this. And why not share it? And I know we've touched before on unbury your birth, and that early on in what I was doing online was really similar in the sense of I went through something and I did not know I didn't know what to do about it. I had no idea where to start. I didn't have the vocabulary to describe what was happening to me accurately. I didn't know how to push back and say, no, 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 I need something else. Like, this isn't right. And
Right.
that was kind of the start. And then what I'm doing now, again, is just trying to find the right words to describe what's happening. And also, um, again, kind of that nurse, but also, 30 something, 40 something year old woman situation of a lot of us go to the doctors and or seek healthcare, complain, express legitimate concerns, and we're not
Right.
heard. And again, this isn't so much to go down that particular hole as to I really think it's people need that language to be able to really specifically articulate what's going on. And it's not
Right.
fair to expect that people outside of the system would know how to do that. And then for my experience going, wow, I'm a pretty experienced nurse. I've worked in the ER, like I've worked in many different settings. And just, I remember like the physician who initially assessed me, he told me that I get many headaches and that my eyes were very tired. And the fact that again, I got treatment. I did, they did a CAT scan, that kind of like I had the headache treatment. But point being was I told him at the outset, as well as during triage, that I have a history of headaches. I have very
Right.
specific headaches. I know what they are, like where they start. I get ones that they go over my eyes. This is different. This
Right.
is different. And I could point to where the pain was. And what ultimately ended up happening, and we found out with the MRI and then neuro-ophthalmology, was that the points where I said it hurt, they were bleeding. Like
My
my
God.
optic nerve and my like ocular muscles were so inflamed and edematous that they were actually bleeding.
Wow.
And I just again, that kind of experience is so invalidating, and it's not fair because it delays care. Like it was
Right.
not an appropriate assessment in combination with I had other subtle neuro symptoms that I think if you had put them together that you might have. And I also just in terms of that early process, I want to bring up a point again, kind of a nursing piece of when you notice something that is atypical or your gut says that's weird. am I seeing what I'm seeing? Don't question yourself. Like, believe what you're seeing. If
Right.
go get somebody else. And if you are working with a physician who does not want to hear that, and you have a concern and you think you're seeing something, you've got to keep going. Because I think I would say 4 different nurses came in to look at my pupils. And I ended up having a very specific and very kind of funny, they called it, I think a leg. Like it wasn't a true like sluggish, like it restricted and then there was a leg and then it followed. And so I think
Right.
all of those nurses saw that. They noticed it, but they weren't, again, for whatever reason, they didn't believe that or the whatever.
Mm.
But that's, I think, really where sharing it is helping me cope with it. Number one is it's talking about it.
Right.
My spouse is not someone who's in healthcare. He also has a very, like, very positive attitude. So sometimes, like, talking about the really real realities of some of this or
Right.
the unknowns is hard. So it's nice to share in that sense publicly. So I ended up with a really sudden over a course of 6 years, I should say. I had a very distinct prodromal period where I was seeking care. I was symptomatic. Things were weird, but there wasn't anything explicitly there diagnostically.
Right.
And so again, I got used to just ignoring things or being like, oh, that's weird, but like that's part of it. And I have a
Right.
TRE1 malformation as well. So that was really, I was followed by neurosurgery every 2 years, but that's considered kind of like, they didn't think that that was what my symptoms were from, if that makes sense.
Right.
So I got pain in my left eye, just dull pain. And it felt like a headache at first. And again, I ignored it for a week, but then I was like, it normally, my headaches do go away. Like they can be persistent, but they don't stay
Typically go
forever.
away.
Yeah. Or they'll ebb and flow. And it's like, oh, Tylenol wasn't touching it. And then I actually went to a conference on, like, I can't remember the date, near the end of April. And I was on a panel. I was sharing like what I was planning on doing in the next year. And on my way home, I got off at the wrong go stop, which I have never done in my life. I'm from
Wow.
Belleville. So if we take the go, you go from Oshawa, you go to Toronto, and then you go to Oshawa. And I didn't notice that I got off at the wrong stop until I was inside the Pickering station.
My gosh.
And I knew that was not normal, but it also was very subtle. Like it was like, oh, maybe I
Right.
wasn't paying attention. I'm on my phone. It was a busy day. So you justify it to yourself, right? You're like, oh
Right.
yeah, that's weird, but okay. The same thing, it was weird for me not to stay and go out for dinner or meet up with some of the people that I hadn't seen. Um, I keep to myself a lot of the time, but if I'm going out, like I will just squeeze everything I can out of it. And I went home right after, which also was unusual. And then the drive home,
Right.
I noticed very subtle vision changes. I had noticed some at the conference when I looked down at paper, but I didn't notice it when I was looking up. So
Right.
again, all of that kind of added up. Then the next day, I think it was just combination of being tired the big day before. I had excruciating pain that I did then go to the hospital with, but I
Right.
was told it was a migraine at that
Jeez.
point. They did looked at me, he's like, well, would you like a outpatient ophthalmology referral? And I was like, yes, please. Kind of like, I don't know what I need. Like my eye really
Right.
hurts. The other thing, again, if we're going all the details, is I had also had almost 2 weeks of incontinence
Wow.
in probably 2 weeks before that pain happened, of in the sense of like urge, coughing, stress kind of thing, which again, I'm like, I've had 3 kids, and I've had this persistent cough. Like I had something going on and I thought, but then I realized I was like, after like, again, once the kind of dominoes fell, I was like, that's not happened to me in the last never. I won't say never, but in
Right.
terms of like you go through pelvic floor physio, it got to the point though when I did present then to the other hospital, basically I was numb from like the top of my pubic bone down like to my tailbone. I had to stop wearing underwear that I normally would wear because it hurt and just things like that were very weird. But again, you're like, oh, maybe it's this or maybe it's that.
Right.
And I'll see how. But then once you put all of those pieces together, so all of that to say, I had some back and forth with the outpatient ophthalmology. He was so fantastic. Like he was so, so good, but his hands were kind of tied because, again, we're in a different city. He's working as an outpatient. Now we have this new system. I don't know if you've heard of Lumio or at his outpatient clinic, even though he's the ER on-call doc, doesn't talk to the hospital system. It just, there's delays and delays. And also I didn't have the vocabulary. My vision was fine before. All I know is like, it's kind of weird. And the thing was, it ultimately was, I couldn't describe the loss of color. I didn't know that there was an absence of color in the sense of, I just don't know how to describe that. And I said things felt kind of blurry, but what it was washed out. And so red was, and he tried so many ways. This was also, again, a nursing assessment note of ask the question in a few different ways. Say, some people sometimes describe it like this, or some people might describe it like this. He said, some people like percentages, some people use this. And
Right.
then when I got home, I was like, oh, I see what he's talking about. But the part that I think is just like really shocking to me is I did not know as a nurse anything about optic neuritis and how it is a absolute classic sign of an MS attack or some sort of neuroimmune attack. And it is one of the most common presentations of that. And I'm like, how did I not know that as an ER nurse? And how many women have I ever assessed that have come in with headaches or their eyes are sore and we've given them Maxaran and Benadryl and sent them home?
Right.
Yeah. So there's a lot of those pieces that are crazy. But I must say, once I went to KGH for like, that's the catchment kind of next level care center. And
Right.
they were phenomenal. The care was excellent from the triage nurse who like she listened to my story. And even like I saw her when I described certain things, she's like, oh, that sounds like a subtle anesthesia. And I was like,
Mm.
she knows. Like she is putting these pieces together. And I genuinely believe, I don't know who she is, if maybe she's listening to this, is I think she went and she spoke directly to whoever was the doctor and saying like, she needs to be seen. You don't really even need to see her. She needs to be seen by neuro. Because when he came to assess me, he was like, I hear you don't really need to see me. You need to see somebody else.
Right.
Then all along the way, it literally was atypical. Every piece of my puzzle was atypical and it just did not quite fit.
Right.
Genuinely, I don't think I was believed the entire time. Again, I say that not as a critique of that particular care setting. I think just it was so subtle.
Yeah.
And my gait was one of the big indicators that I also didn't know until I tried to do like a heel toe walk at home and I could not.
Wow.
But normal walking, like but all of this to say, I get admitted. I have a lumbar puncture. I have HIV and syphilis screening again, which I'm like, oh, goodness, wouldn't that be a fun thing to twist this story that that
Right.
is where
Oh
we're
my gosh.
going on top of that my spine is full of lesions. You do like meningitis, but I really didn't have any infectious symptoms and that didn't make sense. But the MRI ended up showing I have a significant like lesion load on my spine. So basically my
Wow.
C-spine has them all there. And then the part that was very atypical was the fact that my like T9 to T12 has a significant amount. And so like basically I have lesions on my conus, which again, didn't even know that was like anatomy was a long time ago. And that's the part that again controls your lower body. It's the bottom of your spine that is where everything goes out from. So that kind of saddle anesthesia feeling, I had bilateral numbness. I couldn't tell the difference between sharp and dull sensations. And then it started going up my back. So basically at home, the symptoms started in my pelvis. And then by the time I was admitted, moved down into my legs and my feet. And I didn't realize my bowels weren't working properly. I didn't realize my cough reflex wasn't working properly until I started, like, I could feel like the numbness going up kind of into my chest and the back of my arms. But again, weird. You don't notice certain things until say you're in the shower and you're like, wow, that's really numb there. Um,
Right.
and
Wow.
again, my eye, we had like I had vision changes. I didn't lose all of my vision, but it was really disorienting. And I think that's the other kind of lived experience part that how much our vision and our cognition are connected and how much we rely on our vision for our memory. Or maybe not
Right.
everybody does, but to that kind of that neurodivergent lens is like I have a nearly photographic memory for many things. I thought I had a good memory, but in fact, I just remember what I see. So again, I don't remember I left my keys on the table. I'm like, where did I leave my keys? And I can picture where they are. So when my
Right.
vision changed, I could feel like that it wasn't sticking. There were things
Right.
that it was gone. And it's again very hard to describe, but that's scary when you have a very, very high functioning brain.
Right.
And that was the other thing I kept talking to and making very, very explicit that my background, I've worked with some women and as clients or patients, residents who were wildly intelligent, done
Right.
in like very, very, very smart women. And they fly under the radar for so long because you have like your cognitive reserves, right? And they start off way up here. So even if they drop here, nobody cares because they're still past. But if someone starts here and passes the line, their functional change is actually a lot smaller than someone who has gone from a much higher standpoint and not quite
Right.
reached that threshold. So I kept saying, as like, I'm going to pass your test, but I'm not there.
Something's still wrong. Yeah.
And that was the other part that was scary. It was like, okay, my vision's not okay. Oh my God, I'm using a walker. That's scary. But it was my brain that I was like, I cannot lose this. I cannot do this. And I don't want to. I felt like a fainting goat. That's kind of what I described. It felt like any level of emotion, be it happy, sad, upset, stressed, heat, like just anything, I would be like, oh, I'm done.
My
I
goodness.
wouldn't pass out, but like that kind of fawn response of like, I can't do anything.
Right.
Again, I didn't mention this. I have 3 kids, 6, 9, and 13. It's kinda
Wow.
hard to, be on the ball when you're like, "I can't order chicken wings because I need 24 and I can only figure out how to order 18 of them and not realize that I
That
can't count
something's
to
up.
6." Yeah, there's like the answers they were giving me then was, "We have to wait and see." And it could be days, weeks, or months to know
Right.
what comes back or what doesn't. So that was the part that was like, this really sucks.
And this was like a whole 6-year kind of ordeal, right?
Initially, yes. So right after my
Yeah.
youngest was born, which ironically was around the same time of year. And I also was postpartum during this period. So we had had a pregnancy loss essentially in
Okay.
January. So that same window of like 6 to 8 weeks postpartum ish, my youngest was born in February. Yeah. So back then it started off as pain, persistent like neck pain, fatigue. Then I actually ended up with a rheumatoid arthritis diagnosis because it went from, again, kind of that just general inflammation to active joint inflammation, had eczema all over. I had idiopathic anaphylaxis, which means you have an anaphylactic reaction without any known trigger.
Wow. My
I'm
God.
allergic to NSAIDs. Like it just, I like, I'm laughing, but it literally, like when you meet certain people who do have things like that, they're like, oh, you're one of those. It's like and now having those answers and knowing that like I actually wasn't crazy, I think is
Right.
the big thing. Again, coming back to that anxiety and depression piece is it's like, yes, my mental health is a component. Yes, obviously, like I work in that field too. And like I know how much depression can impact someone physically and mentally and cognitively. But it's like that's not just the only thing at play here. Or
Right.
again, the
There's more.
anxiety, I said, it's visceral. I said, like, I'm not trying to say I'm anxious, that I'm worried about, yes, there's things going on, but this feels like I'm plugged into like a socket. Like my body is anxious, not up here, and
Right.
again, it's that you keep going back. And honestly, my neuroimmunologist, after I shared this, she looked at me and she said, like, did you seek care? Or she asked me, why didn't you seek care? I think. And I said, I did.
You did.
I
Yeah.
did. Years. Rise every 2 years. And they were clear.
I mean, I think
Yeah.
we could probably do a full episode just on women going to
Yes.
physicians and describing their symptoms and not really getting any clear support, or just saying, there's nothing wrong. You do all the tests. There's nothing wrong, but like deep down that there's something wrong. We do like a full episode just on that conversation alone. And I think, as healthcare providers, we need to do a better job at listening to people, especially when just like something is off, right? Something
And
is wrong. Like I know
that's
myself, I
it.
was speaking to somebody about just know, like we are the experts on our own symptoms, on our own bodies. So
Like,
if we are saying to a physician, a nurse that something is untoward, something is different, they need to take that into account and they need to really listen. And it's not just listen, you need to do something. Like do something about it,
exactly.
right? And I think the other piece is you probably felt gaslit, right? You're saying, all of these things are going on with me, and they're just like, well, everything looks fine. And then finding out that you have MS later is just, it's devastating that you had that diagnosis. So you now have that validation, but the process, it was horrible. Like, I
Yeah.
think it's fine to say and for you to say that this was a horrible and terrifying experience, right? I think it's hard to navigate health and then feel like you're not being listened to. And then finally you get that validation, but it's like it came at such a cost. And I think I can empathize with you too, because I'm a mom or nurse or whatever, but it's just, there's so many things that are happening. So it's like school, this, being a wife, that you just, you might feel that something's wrong, but you just kind of, oh yeah, I'll get to a doctor, I'll push it back, I'll figure it out. Or like something might have funny happened and you're just like, well, okay, that wasn't a big deal though. And we just kind of keep ignoring these symptoms that we do have. And it's just because of the busyness of life. But I think it's so important that we take that time to just like, and the interesting where you notice it, like in the shower, you're by yourself, you're giving yourself time to kind of like, oh, this is a point that I'm noticing it. We need to take more time to listen to our bodies. And I think, the times of those quiet parts is when you started noticing that there were things that were wrong. So I think we need to find those times where we're just like, this is time for me and I need to understand what's happening. And I'm so glad you were able to find those times and then get this diagnosis. Cause I couldn't imagine walking through, this whole experience that we have, this journey of life, knowing that something is off and never finding out what it was. So, I mean, you did find out that you had this diagnosis. How has it been navigating this diagnosis as a nurse? Cause I know we sometimes are like our worst enemy because, we just
Mhm.
research everything and then we're just, oh my gosh, doom scrolling. So like, how would you say that navigating this experience has been? And are we our worst enemies when it comes to receiving care?
Big picture, I'm going to be honest, I did not dive into as much research as I thought I was
Good for
going
you.
to.
Good for you.
To be really honest, it was just, I think, honestly, like I was admitted the beginning of May, I think May 5th, like the first Monday of May.
20
I was,
year.
yes, 2025. I was there for like, again, the dates are kind of messy now, but like say just under 2 weeks. I then was sent home and I was readmitted July 7th, the first Monday of July. So I said, it's like my attacks like to come up every couple of months on the first Monday. It was so rapid that I still don't think I've really grasped everything because I went from this has happened, you're hospitalized, you're really sick, you need to go home and rest and get better. But everyone's like, oh, like MS, there's lots of good treatment, lots of people, there was so, I don't even want to say too much hope, but it was like, I think a lot of people were like, oh, it's common. Mine
Right.
is extra spicy. That's what we're calling it because you
Right.
should not have a relapse within 6 weeks. And they're quite convinced that it was a second relapse and that it wasn't just like an extension of the whatever happened initially because it
Right.
happened in my second eye. So I went from my left eye was the initial presentation
To
and
your
then
right.
the right eye was at the end of June, which again felt like literally like I had a sty in like just a dull ache. And I felt like kind of like almost a hangover kind of fatigue. Because keep in
Right.
mind, like I'm still not out of the kind of acute phase of that first attack.
Of the first, yeah.
So
Jeez.
I don't know what it's like. Oh, am I hot? Is that why my left leg isn't working so great today? Or am I
Right.
tired? Did I overdo it yesterday? So those kind of things, I just didn't have a new baseline to judge against either. So all of that to say it happened very rapidly. And then the other part was I was able to see my MS doctor between those visits. and we had had a big conversation about meds.
Right.
And I had made a decision. I hadn't 100%, but I really was leaning towards one. The other attack came. She was on holidays. Again, we can have a conversation about the nurses that we are going to lose and why everything is going to collapse, because they run everything. So Cindy, my MS clinic nurse who runs everything, came to see me in the hospital, and we had a conversation so I could make my decision for the meds and get the ball rolling.
Right.
Then my doctor's like, well, okay, two of those are no longer on the table because of how active the disease is. And she said, we aren't going to wait to see how this works for you. So I
Right.
went from having 3 options that were kind of like high efficacy, they call them, but kind of middle of the road. And I was going to start at the lower end and work my way up. But
Right.
she was a huge advocate of hitting it hard. Like, she wasn't wanting to kind of wait and see, just given how
How everything was
many
going.
lesions there were the first time.
Right.
And so all of that to say, I thought I had a plan, and then the plan had to change again. So there was a treatment I was looking at called Mavenclad, which is like an oral 2-year cycle, kind of like a chemotherapy idea.
Right.
And then we switched to Ocrevus, which is a um, infusion every 6 months. I've heard, again, really good things for people who take it and if it works. So we're just in this phase now. The tricky part, though, is if this is not what it needs, the next option really sucks, which is, I'm not even sure. I think it's called Tysarbi or something like that, but it's a monthly infusion. And if you stop, you end up with usually significant relapses.
My
And then the
gosh.
next thing, which again, I am totally didn't know about, was there are stem cell transplants. And I apparently would, like, my general presentation would make me a really excellent candidate because my function has come back in
Right.
terms, like, I have use of my legs. So they want to do treatment like that with people who haven't had significant functional changes or disability in that sense, but have active disease. And so that is on, like I say, those things are really interesting, but I haven't dove into it yet because at this point it's like, it's not on the table yet. We know nothing about it. So I'm just learning about the meds, and I'm trying to do it more from a patient perspective.
Right. It's so hard to kind of shut off that
Yeah.
nursing perspective
Yeah,
when we are now the patients, and it's so important that we do, right? I think we can't be everything to ourselves as well. And I think
exactly.
shutting off that piece is probably important. There's times when we have to turn it back on, but I think when you're dealing with yourself, I think it's important that you do kind of turn that piece off because you are taking on a variety of other roles, but now it's time to kind of be not in the driver's seat and just kind of, well, you're always going to be in the driver's seat because you're going to advocate for yourself. But I mean, in terms of understanding what's happening to you and trying to really learn about this because it's so new and it was so debilitating in it. But now you're kind of on this new journey, which is, it's challenging because again, there's that whole uncertainty piece. Like, what does this look like? I have no idea. You probably could tell me better. Like, it's one of the most challenging pieces, that whole aspect of uncertainty.
100%. Absolutely. The level of stress that goes along with that, just again, from a personal experience. Someone referred to it as wilderness season, like your
Wilderness
first
season.
attack. And I could not identify more strongly with that. And it's, you're in it alone. You have your supports, but ultimately, yeah, like you're
You're the
figuring it
one
out.
going through it. Yeah.
And yeah, no one else can do that for you. And I think it's nice, like, not nice, that's not the right word, but like, you deserve to just experience it. But on the flip side, knowing what I know about our system and the roles that I've been in, I also know how incredibly important it is that you advocate for yourself and
Right.
you ask for
100%.
what you need. And again, apparently I was the first person who's ever asked to see a copy of their MRI on the neurology floor after this.
I
And I
mean,
thought,
right.
what? But also for me, as like my professional background is, I have read a ton of MRI reports when it comes to, neurocognitive things. And I understand not everything, but I have a really good understanding. And it makes sense. I have almost a centimeter lesion in my cerebellum. It impacts a lot, or it could
Right.
impact a lot. And it makes sense with what I'm feeling. But the other part was they were telling me verbally and being really, really like helpful that way. They weren't just being vague, but part of it was like I was not retaining things, and I needed to see it on paper so I could visualize where things were.
Yeah.
And then kind of line up of like, oh yeah, the one that's there, that would make sense for this or that. So yeah, I found that funny. I'm like, really? No one's ever asked for a copy of this? She looked at me and she's like, or she's like, the doctor talked to you about it? And she was younger than me. Like she had some experience, but I knew she was probably fairly new nurse. And I said, yeah, she did. I was like, it's crazy. She's like, it's fucked.
We won't talk about the bedside manner.
But honestly though, what I mean is I needed that. I needed someone to really genuinely just acknowledge, like, this is
fucking
crazy.
Crazy.
Like,
Yeah.
that's all I needed. And
Yeah. It's fair.
again, like I needed, like she read the room correctly, I think is where I'm going with that. And
good.
Whereas again, like the people in my life is like, I don't want to info dump. Like the parts that I actually have to logically work through, because that is scary to them. Whereas for me, it's like, I know this information and I just need to kind of like process it. And the other thing, as I say that, is the MS. She said something to me that I could trust her. I trust her entirely. And when she said our goal is to preserve your brain volume, I was like, okay, you got me. This is what we're doing. Because again, my experience with folks with this diagnosis is nearing the end of their life or in the final, stages of that journey where maybe they're in a secondary progressive phase, or you're seeing that sudden change in cognition, which is so fascinating that you can have so many asymptomatic lesions that you do not, which I don't have at this point, but that's one thing I've learned is people can have asymptomatic lesions, which our brains rewire around when we're young and healthy, and they fix it. And we don't notice that there's any issue.
Right.
And what happens is then we all of a sudden start to age. And as we age, we lose brain volume as a normal part of aging. And those little rewired areas disappear. And now you have a big gap. So that was the other part where kind of validating, not just for me, but for some of the people I've worked with that have had these very similar stories or that story where like mom changed overnight. And It's like, you know what, maybe it's like, there might be more because we didn't have this type of technology or the imaging that we have now.
Right.
And again, people had to fight a lot harder. So I think that part's kind of neat in that sense. So those parts, I'm getting my nerdy, like neurocog side. It's filling my cup in that sense. But I truly like the pace that it's gone at, I think is the hardest part. Because again, as you know, most things don't move quickly. A referral to that clinic alone usually is 18 to 24 months.
And you got in pretty quick.
I got in within 5 weeks of my discharge.
That's
4
amazing.
weeks and so again, this is a story of a physician who looks at their referrals and triages them based on the picture of
the whole clinical picture.
And I think that says a lot to the type of care that I have received because of that. It's gotten done quickly. The same with like the actual treatment aspect, which again, for me, I'm fortunate and I'm very privileged to have the support that I said, sure, I can drive for my first treatment. It's 5 hours that you're somewhere that you have to have a driver that takes you because you get other meds. So my second treatment will be locally, but I said, no, like get me going as soon as possible because you could have a delay because you're waiting for an actual treatment. So again, the whole world of pharmaceutical companies and the case managers that kind of manage your drugs, and then they deal with the pharmacies and all of that stuff. So that part was really neat. But the funny thing was the nurses themselves, when they were going to tell me, like looked scared and sad. And I was like, no, that's fine. Don't worry about that. Just how quick can you get me out of this overflow room? That also was very hard. To be a patient in hospital.
Yes. And especially, well, I don't know if you've encountered this yet, but like if you end up being cared by someone that you worked with is also another experience. You've been navigating this kind of with grace. And I shouldn't even just say with grace, but you're navigating it in a way that works best for you, right? You're doing those things and having those instances and recognize those instances to say that, hey, for example, I need to see the MRI. I'm a visual learner and that's something that will help me, having those moments, like you said, with that nurse where she got it, right?
Yeah.
Where
Yeah.
you can have those moments where you can laugh, but also being able to say to yourself too that, some of this is really difficult and, you're going to go through those peaks and valleys. And I think for anybody who's going through a new diagnosis, just to say that that's okay. It's okay to laugh when, yes, you have a diagnosis that is horrible, but but we have to laugh. We can't always cry. Yes, we'll have those moments, but sometimes laughter is what is needed, right? Maybe that's the best medicine at the time. And I think that it's important that we see that we can navigate illnesses and diagnoses differently, and that's okay too. And I think that that's what makes us human, right? In those moments where we find ourselves and we're like, I'm not too sure what to do, but I'm gonna do this. I'm gonna laugh. I'm gonna do a little research, or you know what? I'm gonna do nothing. And I think that's perfectly fine. But lastly, what would you say to other nurses or other healthcare professionals who are navigating a new diagnosis or illness? What might you say to them?
Well, that's a really good question, Amy. And I think
Or just one
it's,
piece of advice? Like what would your
yeah, I
with
think number
everything you've
one,
gone through? Yeah.
the show will go on. Do not worry about the next shift that you were supposed to work. Do not worry about the shift that you took from someone else in 3 weeks that you might not be able to cover. That part is they will figure it out. And that is not your responsibility, number one. And I think that's a really hard thing for a lot of us. Like, again, I knew I was going to the hospital on the Monday and I worked like as much as I possibly could the weekend before because I was like, well, I'm not going to be doing this for a
Why do
while.
we do this? Why do we
Right.
do that to
So
ourselves? Yeah.
that is my genuine, I think deep down, it's fine. People will carry on without you. You're valuable and all of that, but
Right. But
yeah,
they're gonna figure out what the next
yeah,
steps are for workplace planning. Yes.
exactly. And the other thing is that I deeply, deeply believe that healthcare as a whole system needs more of us in it and more of us to stay in it. Because if we do not bring in this element of lived experience and understanding of what actual accessible care looks like, we're hooped, basically, like for lack of a better professional word. I really think that decision makers need to be people who live in disabled bodies. Healthcare policymakers need to be caregivers and understand what that actual feeling feels like when you have to make like literal impossible decisions.
Yeah.
And I think that's my big thing is you belong here. The system will work real hard to keep you out. Like we talked at the beginning, it is not that great at finding and seeking accommodations.
Right.
But that does not mean that your experience isn't going to change things.
Right.
And I will say one of the most impactful things for me was one of the nursing leaders that I worked with in a long-term care home, who right now she's like contacting me all the time. She just retired herself and she was very open with, again, I don't know what the finer details, but she lived with chronic illness. She lived with pain. She lived with very complex health things. She had a complex life and
Right.
she took the time to be an excellent leader and take the time to know the people. And I think that's the part where, like, don't let them tell you you shouldn't come back or the workload is too much or they can't make
Right.
it work for you because your voice is going to matter and your experience is going to change something at some point. And it may be big picture, or it might just be as simple as, again, on the shift that you're working, that you share something with someone and that changes how they go forward. So
Yeah. No, I think that's really beautiful, Emily. Like I think, first and foremost is that, we have to recognize and understand that, we are important. Like you said, the show will go on. And I think that as nurses, sometimes we're trying to cover that last shift. We're trying to do this. And it's like, no, we need to put ourselves first. So we put patients first, but when we're sick, it's time to put ourselves first because at the end of the day, we have people who love us. We have our children, we have our spouses, we might have our parents still. And, we are the world to those folks. So at the end of the day, we do need to take care of ourselves as well, because I will say this time and time again, at the end of the day, that organization will replace you, will hire someone else. will do whatever they need to do to make sure that shift is covered. Only one person, and you are the world to those other people, so you need to look after yourself. And like you said, and then the other piece is to be involved in a different way. I think you're 100% right. I know we have accreditation where they're like, oh, we need to see patients and families and advisors, but I think at the end of the day, we can't do checkmark solutions. Either they're at the table and they have actualized power to make changes and policy implementations, but we can't have people coming in sharing their experience, which is knowledge, which is transformative, and not, really doing anything about it. And I would say, I think patient and family advisors should be paid. It's work to share your personal experience and
Yes.
your story that changes the healthcare system for good. So people, like you said, in disabled bodies, people who do suffer chronic illnesses, people who are coming to the hospital systems to share this information that is life changing in some aspects, should be paid for that, because that is considered work. So again, I'm so thankful that you were here to share your story and your experience. Before we go, is there anything else that you'd like to add, Emily?
Actually, yes, something, oh my goodness, it had just come and go along the lines of advice. And wow, that this is one of the actual
Oh,
real
dear.
life things.
It's okay. It's okay. And if it
The
comes back,
switch.
we can
I'll let
jump
you
back
know.
up.
No, it's funny, but no, it was really just, I do know what it is.
Yes.
It was about, I do want to circle back in terms of that picture of the institutions and things like that. What I can say is that throughout all of this experience, the people who have reached out to me, who have supported me, be it just again, checking in, sharing my story, whatever, I would say 90% are people who I have worked with
It's so
or
nice to
people I
hear.
have cared for, that I've
Wow.
maintained, again, kind of that um, longer journey. And it's like that tells me, again, that's what it's about. Like, it's not about the shift. It's like each place that you've gone, you've made a connection. And that I hope the rest of the journey is those connections keep being made, because I think that's the really, really neat thing about it. And it reminds you again that like you are important there when you are at work. You do have family. They they're there for you, but at the same time, you are allowed to take care of yourself, and they should
So
have your back, right? That I
I'm
think is
so
where I'm
glad
going with it.
yeah, no, I'm so glad to hear that you got that support and that love and that compassion of, people that you've worked with and people that you've helped support rally around you. I think that's beautiful, and I think that's absolutely needed. We need to see more compassionate folks that, can say, yeah, I think that there's something I might be able to do to support Emily, or, maybe I can bring her a meal, or I can have a conversation. I think that's more of what the world needs. So yes, and we definitely, and the other piece is, yeah, we need more nurses to stay in the profession, and that's a whole other conversation. And I think that, at the end of the day, we'll keep sharing our patient stories. We'll keep sharing those positive experiences, but also talking about some of the challenges as well. And hopefully that'll bring some more passionate people that are willing to fight for change in the healthcare system, that are willing also to stay within the nursing profession. And also, we do need to shake things up a little bit here, though. There's a little bit of work that nursing has to do. And I'm looking forward to be here with you and having the conversations that we can shape the way nursing looks together and the way that healthcare looks together. So thank you so much, Emily, for coming on The Gritty Nurse. I'm sure we'll probably have more conversations. And again,
So
please share with me all your links. I'll post them here where you can see them on the YouTube as well. And yes, we want to hear continuously from you about your journey. And if there's any way that we can support and help, please let us know. And we'll put any links in the bio as well.
fantastic. Thank you so, so much for having me, Amy. And like I said, this was certainly a bucket list podcast interview.
Oh my
So
goodness.
it was a great start to the first week of school too.
Yeah, no, my pleasure. I know you're in Belleville, but maybe we can figure something out at some point in time.
I think that would be a great idea. Thanks.
All right. Looking for a great gift for a nurse or someone who needs to learn about nursing? Check out my national best-selling book, The Wisdom of Nurses: Stories of Grit from the Bedside. Thank you so much for listening to The Gritty Nurse with Amie Archibald-Varley. If you're watching on YouTube or listening on Apple Podcasts, Spotify, iHeartRadio, or any other podcast platform, please hit the subscribe button so you'll never miss out on any awesome episodes from The Gritty Nurse. Thank you so much, and stay tuned until next time. Stay gritty.